gonna first okay, very good. So thank you very much for the kind invitation to participate in this important seminar. It is certainly an honor for me to talk to all of you in the School of Public Health and all members of the community. So what I want to say first is that I do have a program here at UB that is dedicated to study the epidemiology, pathogenesis, and infection prevention of infections that affect the digestive system. And then to conduct this study, we have collaborators in different parts of the world. And part of the mission of this program is not only to understand how this will happen, inform the community of our results, and to develop programs that may decrease the burden of these diseases in the community. Another important mission is to educate young investigators in the area of clinical studies or scientific areas of infectious diseases. We do this by establishing these collaborations and going to different countries and conduct studies of different kinds, as well as conduct studies here in the area. Some of the collaborations that we have include institutions in different places in the Americas, including United States, Mexico, Central America, and several countries in South America. We also have collaborators in Europe, including Netherlands, Germany, as well as Bangladesh and Pakistan. In conversation with the faculty at the School of Public Health, I had the opportunity to meet Licka, which is one student from Senegal. So we now have the opportunity to put an arrow in African continent. And with her, we have been working and learning about hepatitis C. We had also been able to discuss issues that happen in countries where we have a lot of health disparities, including the countries where we come from, but also here in the United States and specifically in Western New York. And specifically, we're going to talk about hepatitis C in this seminar. Briefly, the hepatitis C is a virus. The genome is made out of RNA, similar actually to coronavirus, only that this particular virus is very small. It's only 9.6, which is basically 3 times smaller than coronavirus. And this particular virus has a predilection for the liver. So it gets into the hepatic cells to cause disease. A little bit of history. So the history of this goes back to 1970s, when investigators were interested in analyzing why some people that receive transfusions, blood transfusions, develop hepatitis. And the first virus that was associated with hepatitis due to transfusion was hepatitis B. Until Dr. Alder found that there were some individuals that would lead, that will have hepatitis after transfusion, but this blood was coming from individuals that were negative for hepatitis B. Subsequently, they continued seeing these particular cases, and they suspected that there was a virus that was associated with this hepatitis, but they couldn't see the virus, they couldn't find the virus, they couldn't notice what kind of organism was this. So at the end, they decided to call this agent hepatitis non-A and non-B. Subsequent studies that were more refined led to the discovery that if blood is obtained from individuals that have received a transfusion and develop hepatitis, these individuals' blood can be given to non-human primates and cause hepatitis in those human primates. So that was interesting, but again, they couldn't see the virus until 10 years later, more than 10 years later. Finally, filtrates from blood from these monkeys were cloned into E. coli, and antibodies from individuals that have hepatitis were able to recognize proteins expressed by the virus. And when they analyze these clones, they identify a piece of DNA that was identical to similar viruses in the family of flavivirus. So eventually, another study used these particular RNA pieces of DNA that included the entire genome of the virus. They injected them in the non-human primates, and they were able to see that these were causing the disease, and eventually they were able to see them under the microscope. And then, thanks to these studies, these 3 individuals were recognized with the Nobel Prize 2 years ago for all of these discoveries, which not only were able to identify the virus causing hepatitis C, but they were also able to allow other people to develop diagnostic testing, develop antivirals to treat the disease, and allow many other people to do many different studies in this particular field. So thanks to this diagnostic testing, now we know that basically we have kind of a pandemic of hepatitis C. Every single country in the world has cases of hepatitis C. Some countries now depicted in red and orange and yellow have significant number of cases and significant number of deaths, among them actually United States, but more severe the situation in Russia, Afghanistan, Pakistan, Egypt. So what happens in the United States? So in the United States, one of the things that we were interested in learning about was what is the issue of hepatitis C and health disparities. And as you can see in this graph that is actually from the CDC, we see that certain racial and ethnic groups are more affected than others. In this particular one, the number of cases in the Native Americans has significantly increased over the years. This is from 2004 and 2019. Also, the number of cases among white Americans as well as Hispanic and Black. Interestingly, if we look at the graph on deaths, then you start seeing even more pronounced the disparities in which we have American Indians first, then Black, then Hispanic, and then comes white and Asian. Another important aspect that we wanted to learn about was the social determinants of health. So certainly in this particular graph, that was a part of a publication from Dr. Talal, one of my colleagues working here at the School of Medicine. But he found is that certain factors, social determinants of health factors, may improve individuals to pursue care for hepatitis C. And among them, you have, for example, being employed, having been married, for example. And in contrast, you have other factors that prevent them to seek care. And among them is initial use of crack, of cocaine, criminal activity, unemployment, and so on. Now, as a pediatrician, we also was wondering about what happens to children. In this particular graph, what I show is basically the rates of reported acute hepatitis C by age. And as you can see, the age groups that have the highest number of cases are age group between 20 to 29 and 30 to 39, which basically corresponds to the childbearing age in women. And therefore, you may suspect that because of this significant increase over the years, this population will lead to babies that will be exposed to hepatitis C. And then, in fact, in this graph that was from a publication from 2019, what we see here is that the number of women, pregnant women, that have opioid use disorder, and that in addition have hepatitis C, is really high and has increased over the years twice. So basically here is like 200 for 1,000 deliveries. This is in contrast with women that have hepatitis C but do not have the opioid use disorder, a difference that is basically 100-fold. So as you could see, this certainly is an important factor to take into account, especially now that we are going through the opioid epidemic. In addition to this, it is known based on other publications from other people that infants that are born to hepatitis C infected mothers, they have suboptimal testing, that infants from hepatitis positive mothers who are actually actively using IV drug use, and they have lower rates of testing. That in addition, incarceration on some of these women, so the stigma of being positive for Hep C and being opioid users also lower the rate of testing, to the point that all of these factors certainly are contributing to the underestimation of the real rate of vertical transmission of hepatitis C. So with this in mind, we met already probably 3 years ago, before COVID pandemic, with a very important group of people that included the Erie County Health Commissioner, Dr. Bernstein, the head of the Department of OBGYN, the School of Medicine, Dr. Bernabe, all members of the pediatric department, including Dr. in the Division of Neonatology, and certainly the people in the infectious diseases group, basically my team. And then we basically had a brainstorming sessions, and some of the idea that came was that, okay, we need basically to test pregnant women that come in labor when they have not been tested for hepatitis C. And another thing that I proposed was to start a pediatric hepatitis C clinic. So what we did was contact hospitals within the area that included at this moment the Ochai Children's Hospital, the Millers Fillmore Suburban Hospital, Sister Hospital, which are hospitals that basically deliver babies. And with this, we asked them to refer these infants that have been born to mothers with hepatitis C positive testing to our clinic, so we can do evaluations, testing, and provide information to these parents. So with this, we basically were able to increase, and we are still increasing the number of these hepatitis C exposed infants in a significant number, and this number is going up, and we hope that we will continue to evaluate these infants and probably invite other hospitals also to participate in this program. So what we will do today is basically let Licka give you information of what are these kids and what happened to them and what happened to their parents. And then this is also part of, we are contributing to the program that the New York State has, which is a program on the Hep C elimination plan. So with this introduction, I will let now Licka provide information on her studies and her research.
Dr. Gómez, as we switch to Licka, please know that your voice is fading in and out when you are speaking, so you may want to adjust your microphone. Over to you, Licka.
you. I will start. We share my screen. It's okay.
Perfect, thank you.
So I'm going to talk about the retrospective analysis we have done on hepatitis C perinatally exposed children in Western New York. So a little bit of background. Hepatitis C is caused by a virus called hepatitis C virus or HCV, which is an hepatotropic virus from the Flaviviridae family. The virus is classified into 7 genotypes and 67 subtypes, and it can be transmitted from person to person, which is a horizontal route of transmission, or from a mother to her baby, which is a vertical route of transmission. According to the World Health Organization, there were in 2015, 71 million people infected with hepatitis C, and 399,000 deaths were related to the disease. In the United States in 2019, 123,312 chronic cases and 14,242 hepatitis C-associated deaths were reported to the CDC. And last but not least, in New York State, 6,175 cases and 556 deaths were reported in 2019 to the New York State Department of Health. So infection by HCV occurs primarily via exposure to HCV-infected blood or bodily fluids. Some factors have been identified to increase the exposure, and these factors are blood transfusion, organ transplantation, or injection drug use. Injection in 2018, 60% of the prevalent cases and 80% of the newly diagnosed cases in the US were injection drug users. The person which is infected by HCV goes to 2 sequential phases. The first one, which is the acute infection phase, is the name given to the first 6 months of infection. During that phase, the person is generally asymptomatic and is able to clear the virus before the end of that phase. The second phase is the chronic infection phase, which starts right after the end of the acute infection. So it's beyond the first 6 months of infection. The issues with that phase is that clearance of the virus is rare, and the infected person is potentially exposed to complications like fibrosis, cirrhosis, hepatocellular carcinoma, or even death. So HCV in pregnancy and perinatal transmission. The prevalence of hepatitis C in pregnant women is estimated to be around 1 to 2% in United States or European countries, but maybe as high as 8% in developing countries. The global prevalence of the disease in the pediatric population is between 0.05 and 5%. The risk of vertical transmission or perinatal transmission, or again, mother to child transmission, is estimated to be around 6%. And finally, perinatal transmission is known to be the primary cause of HCV infection in the pediatric population. About the risk factors associated with vertical transmission, there are studies have identified some risk factors associated with an increased likelihood of vertical transmission. The first one is maternal HIV-HCV co-infection. A study conducted in 2020 showed that there were a 1.94 increase in the odds of vertical transmission in infants born to women with co-infection compared to infant born to women with only HCV infection. This odd ratio was increasing to 2.86 when mothers were HCV viremic. The mechanisms behind this risk factor is that the fact that HIV weakens the immune system of the mother, it does benefit to HCV replication and high viral load. The second risk factor is mother's high HCV viremia. It is known that the risk of vertical transmission is proportionate to the increased level in level of viral load. Sorry. And finally, re-exposure of the neonate to infected blood. Other studies have shown that prolonged rupture of membranes or invasive monitoring of the fetus during the pregnancy might increase the likelihood of perinatal transmission of the virus, but these results are controversial. So some challenges we have. The first one is that the number of HCV cases associated with injection drug use is increasing among women of childbearing age. Second, many HCV infected women of childbearing age are not likely to be reported in state-based surveillance systems. Also, there is no universally accepted testing and screening protocol implemented for infant under risk to date. And as a result, the percentage of testing at the national level, so in the US, is around 8 to 45% among HCV exposed infants. Also, a study conducted in 2018 in Cincinnati showed that 66.7% of maternally acquired HCV cases were being missed. And finally, it is important to detect and follow this infant up because we can later initiate treatment for them, also prevent further transmission of the disease and prevent progressive complication once in adulthood. So why did we conduct this study? We noticed that there were limited data tracking HCV infected women and their children in New York State. And as a result, there was no estimation of the testing levels among HCV exposed children in the area. There were also a gap in knowledge about the burden of vertical transmission of hepatitis C. And also there was a lack of information on maternal or infant's characteristic influencing the likelihood of testing or the likelihood of HCV infection. So our specific aims for this study: first, we wanted to conduct a retrospective short review of children perinatally exposed to HCV in Western New York and measure the proportion of HCV testing and HCV infection in that population. Our secondary aim was to determine if there were demographic, clinical, or behavioral factors of mothers or children associated with, one, the testing of HCV exposed children, and second, the occurrence of perinatal transmission in our population. So the study design, we conducted a retrospective study on children perinatally exposed to hepatitis C virus. For selected we then accessed and screened electronic medical records or EMR of selected children and electronic medical record of their mother if available. We then collected their information and those of their mothers about variables related to demographics, health, and behavior. These data were entered to an Excel database, and we analyzed them to determine frequencies and percentages before identifying predictors of testing and infection. So the study population was children born to HCV positive mothers living in the Western New York that were seen at the infectious disease clinic between January 2011 and December 2021. So we included children that were perinatally exposed to HCV from HCV antibody positive mothers, children who were less than 5 years old of age, 5 years old at the time of the first visit, and children born to mother with or without HIV infection. We excluded children older than 5 years old at age at the time of their first infectious disease visit. We excluded those born to mother with negative HCV antibody test, and children without any identified risk of perinatal exposure to HCV. So our results. To define our sample, we went from 604 medical record numbers from infectious disease consultation and ICD codes. We removed a medical record number of patients who visited the infectious disease clinic for other disease. We also removed patients who came at the infectious disease clinic outside of our study period, those who were living outside of New York State, those who were more than 5 years old at the time of the first visit, and we also removed duplicates. We ended up with 133 medical record numbers of patients who visited the clinic between 2011 and 2021 for perinatal HCV exposure. So this table is just displaying some demographic characteristic of the 133 hepatitis C exposed children. We can see that there were 76% of children who visited the clinic before the age of 1, and also that 26% of these children were white. So this pie chart is displaying the frequency and the percentage of HCV exposed children according to their testing status. So in our sample, 95 children corresponding to 71% were tested for HCV. Here we have the frequency and percentage of HCV exposed children here according to their infection status, so their HCV test results. So we can see that 67%, so corresponding to 89 children were tested negative for HCV, while 6 children, so 5%, were tested positive for hepatitis C. So a little focus on these 6 positive children. So here we can see some demographic and clinical characteristic. For example, half of these children, these infected children, were male. 4 out of 6 children were hospitalized at birth, like NICU admission, and 2 out of 6 children were born to HIV positive mother. Always with the 6 positive ones, we have here some of their growth measure at birth. And the main takeaway from this table is that 5 out of 6 of the infected children were diagnosed to be small for gestational age at birth. So we evaluated factors related to children or related to mothers. We evaluate these factors for association with children testing status based on chi-square, Fisher, or t-test. So in green, we have variables that were associated with the testing status. So variables like age at first visit, route of delivery, accompanying person at the first visit, or age at labor, tobacco use, tetrahydrocannabinol use, injection drug use, or opioid agonist therapy in the mother side. Race and ethnicity were not associated with the testing status of the HCV-exposed children. We then tried to measure this association we have seen between variables and testing status. So here we calculated we estimated some crude odds ratios, and this table is showing that the odds ratios were statistically significant for tobacco use and accompanying person. However, injection drug use and opioid agonist therapy were not significant predictors of children testing status. Then for variables that had a significant crude odds ratio, we combine them in an adjusted model, a multivariable model, sorry. And here we can see for tobacco use that the odds of being tested was lower among children born to mother with a history of tobacco use compared to children born to mother without any history of tobacco use. And this odds ratio remains significant even after adjustment for accompanying person. And for accompanying person, the odds of being tested was lower among children living with their biological mothers compared to those living with in foster care or with their guardians. And this odds ratio remained also significant even after covariate adjustment. We did the same process, but here for the infection status of the children. So we evaluated some factors to test if they were associated with the infection status based on chi-square, Fisher, or t-test. So same variables in green were associated with the infection status. So variables like age at first visit, history of respiratory distress at birth, weight at birth, or HIV status of the mother. And variables like route of delivery or HCV viremia were not associated with the infection status of the children. So again, here we estimated odds of getting infected by HCV for weight at birth and HIV status, sorry. And we can see that the odds of being infected was decreasing by 0.187 at each kilogram increase in the infant's weight at birth. Also, the odds of being infected was more than 16 times higher in women born to HIV-infected women compared to those who were born to mother without HIV infection. So we took these two variables, put them in the same model to have the adjusted odds ratio. And when we did that multivariable model, none of the odds ratios remain significant in the adjusted model. So some limitation of our study, there were high proportions of missing data, for particularly for maternal factors, because information of interest were not available in electronic medical records. And in some cases, we failed into linking the child's EMRs to the mother's EMRs. Also, there were poor variability in some variables, and as a result, we were not able to test their association with either testing or infection among the children. And third, our small sample size of 133 children might not be representative of the population of HCV-exposed children in Western New York. On the other hand, we have some strength. To our knowledge, this is one of the first studies conducted on perinatal hepatitis C in Western New York. This is also one of the first studies evaluating potential influence of children's characteristics on testing and infection. And third, the calculated proportion of testing and infection in our sample are within the national range. So some concluding facts. Hepatitis C clinic is allowing the follow-up of HCV-exposed and infected children in Western New York. We have seen that around 1/3 of the exposed children who visited the clinic, were not tested for hepatitis C. This study has helped into identifying infected children, and we have seen that most of the HCV-infected children were small for gestational age at birth. And lastly, the percentage of HCV-infected children we found, which were 5%, goes along with percentages reported in other studies. Thank you for your attention and attending this seminar. And thanks to our collaborators who helped in conducting this study. Thank you.
Thank you so much, Licka and Oscar, for your presentation. I invite our audience members to put in their questions into the chat or comments to share with our presenters. And while you're doing that, I have some questions that maybe I can start us off with. So this was really fascinating. It was great to have the background information from Oscar, and then more of the data dive from Licka. Thank you for doing that. I wondered, you had found among these 133 children that drug use was not a predictor of testing status. And I wondered whether you found that to be a surprising result, given some of the background information that you presented, where intravenous drug use seems to be a risk factor for transmission. So I wondered if this was something that you expected, or whether that's something that surprised you as you were getting these results.
You want to answer, Licka?
It's just to know which variable did you mention? Like, I just lost that part, please. Yeah.
IDU use?
IDUs. For testing, injection drug use were associated with the testing status when doing the basic test of chi-square and Fisher. But when we tried to measure this association, it was no longer significant. And yeah, according to the literature, injection drug use is more known to be associated with the infection status of the infant. And here we test for the infection and the testing status. But I don't know, it's unfortunate or fortunate, it was not associated with the testing status.
Yeah, I think that as Licka mentioned, some of the limitations of the study is that there was missing data, and then there was no specificity regarding the heavy drug use. I think one way to address this issue is actually to conduct a prospective study in which we have a specific questionnaire and we actively ask these questions to the parents when the biological mother actually comes to clinic with the baby. And also, of course, the number of subjects were tested or not tested was small. So I think having more robust data may have given us maybe the same result, but actually significantly when you do the whole ratio testing.
So as thanks for the great presentation are coming in from our audience, I will ask another question. As you just said, there was about 133 participants in this study, and there was missing information on many of them from medical records. So I wonder, will your chart review continue as prospectively from this point forward, or do you feel like you have a good understanding of the prevalence as well as the risk factors and predictors of testing in the Western New York region?
We think that we need some more, we need more data to have some robust estimate and define relationship with these characteristics, which can be maternal or from the infant, to define their relationship with the testing or the infection. So yeah, I don't know what Dr. Gómez thinks, but the idea will be to continue collecting data to have some robust estimate in this area of Western New York.
Yes, and certainly I would agree that it would be very nice to have a more robust data. Some of the things that the clinic has incorporated is a questionnaire that will be part of the medical record, in which we specifically address some of these risk factors. So ideally, the person that comes will fill out information, and this information goes into the medical record. And then we continue doing this either retrospectively or prospectively, then we could address this issue. This study, however, has of course led to other areas in addition to surveillance, which is what happens with these babies that are positive based on testing, which again, this number of 6 will be increasing because probably these 6 correspond to 1 year of since the clinic opened. So it's very likely that we will see even more of these positive ones. And certainly there are many other questions that are raised. So for example, how many of these children will have symptomatic disease? How many of them will have asymptomatic or subclinical manifestations? What would happen when we treat? Are these subclinical manifestations disappear, or will they have still some sequelae because of the infection? There are certainly important questions that we will be able to address now that we know that by testing exposed infants, we will have at least 5% of them positive for hepatitis C.
Thank you. There's a question from the audience, which is, do you have any thoughts on how we might increase the number of babies tested? This would also lead to more robust estimates regarding risk factors for being a positive baby.
Yeah, this is a very important question. And in fact, what we want with this study and in verbal communication with the Erie County is to make the community aware, not only the community, but also the healthcare system, to create awareness that this is a problem and that this is a silent disease that nobody really thinks that exists, and that of course will lead to under testing and under reporting. And then the big problem is that over many years, some of these children end up being adults already with severe problems. So how to address this? So one of the things that was discussed in a meeting that was actually organized by the New York State Department of Health was that certainly there was a need to address the vertical transmission, and that there should be a system in place, a program in place with funding that may allow these clinics to open up in other parts of the state. So we could basically try to reach close to 100% of testing for all of these babies that are born to mother positive for hepatitis C, in parallel with the program that the state has on eradicating the infection in positive people. So yeah, so the question is very important. The increased number of clinics of the ones like the ones that we have here in Buffalo, in different other cities, or the increased number of personnel in these clinics to address the needs of the city, because we are basically only having referrals from 3 hospitals out of probably 7 hospitals that deliver babies in Western New York. And also the implementation of something that Dr. Talal has already implemented, which is the telemedicine. So it's very likely that if we have babies that live in rural areas, in Seneca Nation areas, probably it would be better to do this follow-up through telemedicine, so there will be better access to these communities. So those are kind of the ideas that we have, and hoping to share those thoughts with our Erie County Commissioner and other members of the New York Department of Health.
Thank you. I'm going to hand the microphone to Professor Samina Raja to continue with some of her questions.
Thank you, Kasia. Thank you, Oscar and Licka, for an insightful presentation. I am really intrigued by this whole hepatitis C. Who knew? But now I know a lot more. Thank you very much. As you both know, this particular webinar is partly designed to help faculty who are dialed in, as well as students, think about what it means to engage in research as a faculty and student team, and you have modeled that for us. So this question is directed to Licka. If you had to give advice to graduate students or even undergraduate students about why should they engage in research, and then how did you decide to work on this? Like, tell us a little bit, give guidance to other students who may not be thinking about this.
What I'm saying to, and even what I'm saying to students most of the times who's engaging in university studies for the studies, I just tell them that you need to be interested in what you're doing and be good at what you're doing. Because if you're interested and not good, it can be a problem because you will not go forward, and you can be good and not loving the things you are doing. So it's also a problem. So that's the first two things I will give for a piece of advice to students. And how to choose the research. So it's apply for studies and for research for me. And how I came with this topic is that I have a background in infectious disease. And when I came to the School of Public Health, maybe I'm a little bit so bored, but I just told my advisor that I wanted to stay in that infectious disease topic, and they really helped in finding a faculty that could help me with my master thesis. And I'm thanking them here because they did a great job connecting me to Dr. Gómez so that I can stay in a topic I like and that I have some knowledge on. So yeah, I just chose this one because it was infectious disease, and it is something in the US that it's kind of neglected. So our result could contribute in bringing more knowledge in the literature, and on the long term, improving the healthcare condition of these infants. So that's how it should.
Thank you for sharing that. In addition to your point, really good point about loving what you do and being good at it, you also signal that it is important to have a network of faculty who helped you build a network. Right? I'm sure some of them are online. And then being willing to stick your neck out and asking. So I don't want to lose the word that you use. You have to be bold, which simply means just do it. Go ask somebody. Thank you for sharing that. I have some other questions, but I know that Kasia likely has more science type questions. Back to you, Kasia.
Thank you. So there's a question from the audience. This is for Oscar. Your career sounds fascinating. Can you share your experience working across different schools, medicine and public health, and any suggestions for early career scholars who are interested in doing the same? So sort of interdisciplinary type of work.
Yeah, thank you for the question. So what I can say is that over the years, I have been very much interested in global health, and certainly throughout my career, going from different universities I have found really helpful the networking that I could have with faculty members in the School of Public Health. Because by working with different schools and with different institutions, you will find the necessary blend of knowledge, communication, expertise that may nicely shape the project that you have in mind, either to explore information, to make discoveries, or to propose programs that may help the community. So I'm really pleased with all of the faculty at the School of Medicine that have been working directly or indirectly with me, and certainly I am very pleased with the expertise, with the knowledge, and with the willingness to help not only my team but also help my students, and then that will include different faculty members from the Department of Epidemiology, certainly the statistical Department of Statistics, and many others. So in addition, I also welcome students who may have an interest in studying infectious diseases. We have projects on hepatitis C, we have projects on enteric pathogens, and of course, if there is funding available, then we will be able to go all over the world and do great things.
Thank you for that. I will ask another question, and maybe both of you can share your thoughts. So going back a little bit to your science and the results that you have been sharing with us. So Licka noted in her presentation that the types of factors that you were investigating as predictors of both testing as well as infection had to do with individual level factors. So what are the characteristics of the child as well as the mother in relation to likelihood of being tested and the likelihood of having a positive test. But I'm wondering if you can, each of you, give us your thoughts about whether you think that there are any structural or social determinants that we should also be investigating as predictors, because obviously sort of individual behavior and characteristics do determine risk of infection, but testing isn't only about the individual person or the child, it's also more system-wide. And so I'm wondering if you could each offer your thoughts about which social or structural factors may be playing a role here. What should we be paying attention to as we think about how to both increase testing and also reduce infection? So Licka, why don't you begin, and then we'll have Dr. Gómez share his thoughts.
Yeah. Structural factors I'm thinking about right now, which could influence the testing levels here, is the fact, for like in the US, there is, as I said, there is no universally accepted testing protocol for infant under risk of HCV. So I think that a defined protocol for physicians or for and for hospitals could significantly influence the testing levels for an infant under risk. So this is the structural factors I'm thinking about right now, beyond the individual one. Yeah,
I certainly agree with that. We, the pediatricians, have a a book that we follow. It's like our Bible, which is called the Red Book, which is an edition from the American Academy of Pediatrics. And interestingly, if I look at the editions for the last, 15 years, it's not clear for them to say, yeah, we should do this type of testing in these children. And they have barely addressed the issue that many of these babies are lost for follow-up. So having a concrete guide for pediatricians, and more importantly, to make awareness of the importance of doing the screening and the testing as soon as possible, that certainly will improve the main goal of the WHO, the CDC, and the State Health Department of eliminating hepatitis C, which is an infection that is treatable, and people shouldn't die from hepatitis C. But going back to the question, I see these families coming to our clinic, and I talk to them, and I feel their pains. And one of the issues that have come up is the issue of stigma. And they themselves mentioned to me that sometimes they are kind of afraid, or they have fears of going to a service, knowing that they have an issue with opioid use disorder, or they have hepatitis C, because they may be, in some of these facilities, they may look at them differently, they may treat them differently. And then this would be very important to be analyzed. And some other people have analyzed that area, and they have clearly demonstrated that the stigma is an issue. And if that is an issue, certainly there should be a way to address it. One way to address that has been, for example, the use of telemedicine programs in which patients that have this opioid use disorder go to clinics for treatment through what is called traditionally the methadone program. And this is probably the place that these patients feel safe. So it would be great to integrate not only methadone treatment, but also hepatitis C treatment, as Dr. Talal has implemented pretty much in the entire state of New York. But it would be great also to integrate the maternal and child issue of hepatitis C, in addition to other issues that should be done at clinic that see these patients. Also, social determinants of health are critical, are very important to address. One simple one, healthcare access. So we have many individuals, or many communities with higher rate of hepatitis C. And many of them actually live in rural areas within the state of New York. And again, these are individuals that they don't feel sick. They don't feel the need to go to a medical center, which may be 1 hour, 2 hours, 3 hours away, or even more. So having studying this issue is relevant. The issue of poverty, the issue of certainly are maybe aspects that clearly play a role, and that they should be studied. Hopefully, in the future we could coordinate or collaborate with somebody who may be interested in addressing these important aspects in this particular disease.
Thank you. Samina, okay, I was going to ask if you have any follow-up questions, so go ahead.
That was really interesting, and thank you, Kasia, for raising that. As you might imagine, at CGHE, we're always trying to understand the linkages between particular health outcomes in particular groups as a result of factors that are really not clinical, that are maybe tied to social determinants, but also tied to other things that might not enter the conversation in a hospital or in treatment or testing. And Oscar, you gave a great example of transportation as being one. Stigma being another one, and I don't remember all the data, but I wonder if, so we are, we are a refugee resettlement region. And one of the questions that I had was, is the prevalence of hepatitis C greater? I don't remember the chart, so I apologize. I'm just asking you to recall, but there's a point to this tied to social determinants. So your point about transportation and about stigma, definitely that's a rural issue, but I also wonder how that plays out in our own Erie County and in the refugee population, because they don't, when they arrive for a period of time, they don't have access to transportation services. They're still adjusting. And then the cultural norms are so different within the country than outside the country. I am wondering if you think that this is something that we ought to be working also with our immigrant and refugee community. So just curious about your thoughts, because transportation and stigma, the two things that you mentioned as a social determinant, that to me in my planning head, urban planning head, immediately goes to the larger context in our region that might impact their decision to get tested or ability to get tested. I'd love to hear your thoughts. And then, of course, sorry, one thing to follow up. I don't understand at all the physiology of all of this. I was trying to follow, but there was just a lot. If a parent is at risk, am I understanding correctly, the child is at risk? So Licka is saying yes. So then what that kind of is a cause for concern for, as I'm listening as a non-physician, because what I'm learning from the two of you is that the inequity of this particular outcome is compounded from generation to generation, and that we need to maybe from a local policy and response standpoint have some measures in place, to use Licka's words, that are not individual, but that are intergenerational supports in place. So just, I want to hear your reflections to this thing about we are serving people that are coming from different cultures for whom transportation and stigma is compounded for all kinds of reasons.
Yeah, thank you for the question. So I would say that this is a very important aspect to be addressed, because immigrants may be coming from countries where the rate of hepatitis C infections may be significantly higher than in the United States. In some countries, for example, in Egypt, is close to 20%. Of the population being positive for that. And other countries may be equally higher. So you would say, I mean, if we have patients coming from areas with high rate of infection, it will be very important for them to get tested and to offer help. And then that would include not only adults, but also children. The issue of stigma has been addressed here in Buffalo, not for Hep C itself, but has been addressed for HIV. And then because of this stigma, many immigrant members of this community would avoid going to seek care because they may feel that they may be target for discrimination of some sort. That has been reported, and that is a big concern. And certainly there will be a need to be addressed. I guess the issue with hepatitis C is that since there is for many years there hasn't been any awareness about this. People don't even know that they have it. But that may be actually part of the problem, that people don't know that they are sick and they are sick. So they not only can having a progression of the disease, but they also may be transmitting the infection to other individuals. So I can see clearly that there is a need for something to be addressed in this direction. and regarding the physiology of this or what exactly happened, what I can say is that although in children, many papers have reported that most of them may be asymptomatic and that the progression of the disease is slow. This basically follow a bell curve. Some children certainly will be asymptomatic, probably the majority of them, perhaps 90% will be okay. But we have seen in our clinic that some of these children, they have symptoms. And then they may have issues in the skin, they may have issues with fever that come and go, they may have problems of nutrition because they don't want to eat. And also, I have seen over my career situations in which a child that has a chronic form of hepatitis, they could have a fatal case of hepatitis if they have what we call an insult in the liver by a different condition. So let's say a patient has hepatitis C and all of a sudden eats something that is contaminated with hepatitis A. In a normal child, that child, in a healthy child, that child will have no issues with the infection with hepatitis A and eventually will get better. But if you have a patient that already has an insult in the liver by hepatitis C and gets a second hit by a different infection, that patient may actually end up in the ICU and they may eventually die because of the combination of those two things. So, and we don't have a vaccine for hepatitis C. So I think that in the same way as the NIH and the health system in the United States address the issue of HIV in children, in infants, in which immediately after they are born, they get tested, and they get tested at 2 weeks and 1 month and 4 months, just to make sure that they are not infected. And if they're infected, they immediately are started on therapy. I think that we need something similar for infants that are born to mothers with hepatitis C, especially those that may be at high risk. And the high risk not only may include mothers with opioid use disorder, but may certainly incorporate immigrant populations. So this is a totally very important area to be explored, and that we haven't even touched the surface.
Licka, he's telling you what the next research project is.
Right.
Back to you, Kasia.
Okay, so I have one last question and would love thoughts from each of you. So Licka, maybe you can begin. And my question is this: so this is a hepatitis C clinic, and you wanted to understand the rates of testing and the prevalence of HCV and in children, and yet I understand your sample size of 6 positive children was very small, but 5 out of 6 were born small for gestational age. So to me, that seems that testing in children is late. And it's really to prevent SGA, the testing would need to be happening earlier. And I just wondered from this work and from the way that the clinic is set up, I just wonder what you think are the perspectives for testing either in early pregnancy or throughout pregnancy, so that prevention of these adverse outcomes for the infant can be implemented. And so let's close with that. And Licka, I wonder what your thoughts are, and then maybe Oscar can share his as well.
Yeah, I will start maybe by mothers and saying that hepatitis C is not included in the automatic test we are doing for pregnant women when they are pregnant, during their pregnancy. So maybe it's a gap to know about their children early early during the pregnancy. I think that most of the times those who are, mothers who are tested for HCV or those who have opioid disorder or these kind of things, who come in the hospital or healthcare structure who receives this HCV testing. And also there is another issue, which is that these women of childbearing age or these pregnant women when they are pregnant, they do not receive, they receive a limited prenatal care, so they do not go to clinical visits. And for infant, the recommendation we have from the Association of Pediatricians is that infant can be tested by PCR once they are 2 months old, and should be tested 2 times in a row by 2 months of age. But I would say the gold standard will be to test them once they are 18 months by an antibody test, which is the gold standard. Now the problem is, will the parents remember that she or the father will have to bring the infant for these 18 months tests? That is the problem. So yeah, that are my thoughts. I don't know if we can do testing in utero but just to know the HCV status of the mom could help into forecasting what we can do for the infants once he is born, he or she is born. Over to you, Dr. Gómez. Yeah.
Thank you. Yeah, so I agree with that. Regarding testing, so fortunately in New York State, there was a legislation passed indicating that pretty much everybody above 18 years of age should be tested. And I believe that certainly in many hospitals within Buffalo area, pregnant women are tested, although the question is, what about a pregnant woman that is less than 18 years of age? And again, this legislation may not be the same one in other states in the United States. So there is still a lot of things that can be done that may improve. Now, one aspect that is, I think, relevant to the question that Dr. Carlos was saying is that we are seeing already these babies small for gestational age, again, maybe related to Hep C, maybe related to other confounding factors, a mother that has opioid, use disorder may have other issues. But certainly it will be important to address this problem early on. And then pregnant women, for example, that are HIV positive, they receive treatment throughout pregnancy. So the question is, why pregnant women that are positive are diagnosed as hepatitis C positive, why they shouldn't get treatment? The treatment is only 8 weeks, and then they will not have hepatitis C, they will not transmit it to the baby, and then there won't be any issues related to infection on the baby or many problems related to the infections, such as small for gestational age, liver issues, who knows what other problems they may have. So regarding this, what I can say is that there is a program I know that one program is in Cleveland, which they have a clinical trial right now going on, doing a treatment to pregnant women, and they are enrolling pregnant women from other states too. And hopefully in the future, we will have the possibility of offering treatment to pregnant women that are hepatitis C positive. with the goal, of course, of eliminating hepatitis C on the mother, decreasing the possibilities of transmission to the baby, and decreasing all of the effect that hepatitis C may have on them. Of course, the big question is, are these drugs safe? Some of these drugs that are being used for hepatitis C are very similar to the ones that are used for HIV. So we are hoping that that may be the case in the future. And if that is the case, certainly that will be a significant improvement for this situation in many pregnant women.
Thank you for that response, Oscar. And thank you, Licka and Dr. Gómez, for a terrific presentation, giving us the big picture and then bringing it home to Western New York. And also for modeling the possibilities of a faculty and student working together on research for our series on building blocks of equity. I do want to acknowledge that building blocks of equity began well before our students and faculty arrived here at UB. And in that spirit, I'd like to conclude by offering a gratitude to Licka's former mentors and family members who are actually dialed into the webinar today. And I believe dialing in from other parts of the world where it is late in the night. So thank you very much for dialing in, and we look forward to your continued work and collaboration. Our next talk for CGHE is May 5th, and please come back to that. That talk will focus on the ways in which food equity is impacted in communities and crises, such as Syria, Kashmir, other places around the world. And we will be joined again by a panel of a faculty, a community partner, and a student that worked on research. Thank you all for being here. Be well, everybody. We will see you in May.
Thank you.